You know how sometimes a news story just uh, grabs your attention, puts a spotlight on something maybe you haven't thought much about?
Hmm.
Well, lately, the headlines about President Biden's prostate cancer diagnosis,
Hmm.
you've probably seen them, right?
Yeah, they've been everywhere.
Things like aggressive form reported or what we know and don't know. It's a bit of a jolt.
It really is. It reminds you that these things affect real people, even, people in the highest offices.
Exactly. And that's actually where we want to start our deep dive today. Let's, for a moment, set aside the politics and use this news as a way in, a way to really understand prostate cancer better.
Absolutely.
Yeah.
Because news like this, especially involving someone so public, it naturally brings up a lot of questions, maybe some concerns.
Right.
So think of us as your guides today.
Yeah.
We want to cut through some of the maybe confusing medical talk. Our mission is to explore the science. What is prostate cancer? How is it diagnosed? How is it treated? We're using those news reports as a jumping off point, but we've also pulled together some really solid resources.
Okay.
We're talking actual medical guidelines doctors use, deep scientific reviews, clinical best practices. The goal is clarity for you, not confusion.
Precisely. And just to be super clear, we are not playing doctor here. Definitely not discussing any specific individual's case.
No, absolutely not.
Think of this more like your personal backstage pass to understanding the condition itself. We'll break down the basics, in plain English, look at the latest in diagnosis and treatment based on the research, and ultimately try to connect it back to what it might mean for you, or maybe the men in your life.
Equipping you with useful knowledge. That's the aim.
Exactly. So where do we even start with this? How do we begin to make sense of prostate cancer?
Well, let's start with the main player, the prostate gland. A small gland, part of the male reproductive system. Now, here's where it gets interesting right away. Not all prostate cancers are the same. Some are really driven by testosterone. They need those male hormones to grow.
Right.
We call those androgen sensitive. But others sort of figure out how to grow even when testosterone levels are really low. They become androgen insensitive. And that difference, it hugely impacts treatment approaches.
Okay, so testosterone can be like fuel for some types, but not others, or maybe not later on. Got it. And reading through our sources, it sounds like this is, well, pretty common, doesn't it?
That's a really significant point.
Yeah.
It is very common. One of the most common cancers in men worldwide, actually.
Wow.
And the clinical guidelines we looked at, they state it's the most frequently diagnosed cancer in men right here in the U.S. Interestingly, after numbers were going down for a while, we've actually seen a bit of an uptick in the U.S. in recent years.
Any idea why?
Well, one potential reason the sources suggest is maybe changes in recommendations around PSA testing. That's the prostate-specific antigen blood test. We'll definitely get more into that later.
Okay.
But globally, the research underscores just how widespread it is. And, with populations aging, those numbers are unfortunately expected to keep rising.
That's quite sobering. Are there specific things that make someone more likely to get it? Risk factors?
Yes, definitely. Several factors increase a man's risk. Family history is a big one. If your father or brother had it, your risk is higher.
Right.
Ethnicity also plays a part. Our sources show that black men tend to have higher rates. And probably the biggest factor is simply age. The risk really starts to climb after, say, 45 or 50.
Okay.
Lifestyle factors are also in the mix, things like being overweight. And researchers are looking into environmental factors, too. So it's kind of a combination of genetics and, well, life.
Makes sense. Now, one of the papers we looked at, the molecules one, had this really detailed diagram. It looked like a map showing how normal cells can become cancerous and even spread. Can you kind of walk us through the main stages of that?
Sure. Yeah, figure one of that paper. It's like the prostate cancer origin story, visually. It starts with normal, healthy prostate tissue. Then things can start to change, leading to a sort of precancerous stage. The technical term is prostatic intraepithelial neoplasia, or PIN. Think of it as cells acting a bit strangely.
Okay, like an early warning sign.
Exactly. From there, it can develop into actual adenocarcinoma, which is the cancer. And then the most serious stage is metastasis. That's when the cancer cells manage to break away and travel to other parts of the body.
And along this path, there are all these molecular changes happening, right? What are the first sparks that can kind of set this off?
Yeah, the diagram points to a few key triggers. Things like chronic inflammation or damage to the cell's DNA can be early problems.
Okay.
Then deeper down at the gene level, you often see certain genes get switched off when they shouldn't be, like one called NKX3.1. Others get turned on too much, like MYC. And there's a specific gene fusion, TMPRS2ERG that pops up quite often early on.
So like a series of unfortunate molecular events.
You could put it that way, yeah. It's like the wrong combination of signals setting the stage.
Okay, so those are some early changes. What happens as it progresses? What fuels the move towards more serious cancer?
Well, in that progression phase, the diagram mentions something called senescence. Think of it like cells getting old and starting to ignore the normal rules of growth.
Right.
You also see key brake genes, like PTN, getting shut down,
Yeah.
and accelerator pathways, like ERK-MEPK, getting activated. It's basically the cancer cells finding ways to bypass the body's normal controls and just keep dividing.
And then when it gets to the point where treatment is really needed, what are the big hurdles? I saw terms like castration resistance and EMT.
Yeah, this is where managing it gets challenging. Castration resistance means the cancer finds ways to grow even when testosterone levels are very low, which is what many hormone therapies aim to achieve.
So it adapts.
It adapts, exactly. It finds a workaround. And AMT, that stands for epithelial mesenchymal transition, another clever trick. The cancer cells can kind of change their shape, become more mobile, more invasive. It helps them spread.
Wow.
The diagram also mentions another gene, EZH2, often becoming overactive at this stage, which is another potential target for newer therapies.
So the cancer cells aren't just growing, they're actively evolving to survive and spread. Yeah, a bit daunting. Okay, let's switch gears slightly. How is this actually found? Most people think PSA test, right? Is that still the main thing?
Well, the PSA test, checking that prostate-specific antigen level in the blood, it's definitely been a major tool for years. But, and this is really important, it's not a perfect test.
Okay.
So traditionally, doctors use both the PSA and a digital rectal exam, the DRE, where they physically feel the prostate.
Right.
But the key thing our sources really stress is that a high PSA doesn't automatically equal cancer. Lots of things can raise PSA levels, like just having an enlarged prostate or even an infection. And that's the issue. Relying only on PSA can lead to what's called overdiagnosis, finding slow-growing cancers that might never have caused harm, and that can lead to unnecessary biopsies, anxiety, side effects.
Yeah, I can see that. Worrying people unnecessarily, potentially doing procedures they didn't need. So what's better now? What are the newer tools?
This is where imaging has really made huge strides. Multiparametric MRI, MPMRI, is becoming much more common. It gives really detailed pictures of the prostate.
Better than just a standard MRI?
Yes, it combines different types of MRI scans to give a more complete picture. It helps doctors see suspicious areas much more clearly.
Okay.
And even more advanced is something called a PSMA PET scan. This uses a special radioactive tracer that hones in on a protein called PSMA, which is often abundant on prostate cancer cells.
Like a guided missile for detection.
Exactly. It's really good at finding even small bits of cancer and seeing if it has spread. In fact, guidelines are now often suggesting that men at higher risk should get an MRI before even considering a biopsy.
Wow, that's a big shift.
It is. It's moving towards being more targeted, less invasive upfront if possible.
So if the imaging does show something concerning, then what? Biopsy time?
Usually, yes. That's the next step. A prostate biopsy involves taking tiny samples of tissue from the prostate.
How's that done?
It's typically guided by ultrasound, or increasingly by those MRI images we just talked about, to make sure they sample the suspicious areas. It can be done either through the rectum that's transrectal or through the skin between the scrotum and anus that's perineal.
Okay.
Those little tissue cores then go to the lab. A pathologist looks at them under a microscope to see if cancer cells are there, and importantly, how aggressive they look.
Right.
That's the cancer's grade.
And I bet analyzing those samples has gotten more sophisticated too, not just looking under a microscope.
Oh, absolutely. Our sources mention AI, artificial intelligence, is starting to be used to help analyze the images, potentially spotting patterns humans might miss. And beyond just looking, they're doing more molecular testing on the biopsy tissue itself, looking for specific genetic markers.
Like that gene fusion thing you mentioned earlier.
Exactly, like the TMPRSS2-ERG fusion. And there are other biomarker tests too, like the Prostate Health Index, or PHI. The goal of these newer tests is to get more specific information, help distinguish aggressive cancers from slower growing ones, and ideally help reduce the number of unnecessary initial biopsies.
It really sounds like diagnosis is moving from like a blurry photo to high def. Much more precise.
That's a good analogy.
Okay, so let's say someone does get diagnosed. What happens then? What's the treatment picture look like? It can't be the same for everyone, right?
Absolutely not. It's very individualized. The approach really depends on, well, several things. How far the cancer has spread the stage, how aggressive it looks, the grade. the patient's overall health, age, and crucially, their own preferences and values.
Okay.
So for cancer that's still just inside the prostate gland, localized prostate cancer, there are a few main paths. One is actually active surveillance.
Meaning we're watching it.
Pretty much, yeah. But watching it very carefully, regular PSA tests, exams, maybe repeat biopsies. Treatment only starts if there are signs the cancer is growing or becoming more aggressive. It's often a good option for lower-risk cancers.
Okay, so a watch and wait, but actively watch approach. What are the more interventional options for localized disease?
The main ones are surgery, radical prostatectomy, where the whole prostate gland is removed, and radiation therapy.
Right.
Radiation can be delivered from outside the body, that's external beam radiation, or by placing tiny radioactive seeds directly inside the prostate, which is called brachytherapy. There's also cryotherapy, which uses freezing to destroy the tissue.
So several ways to tackle it if it's still contained. What about when it's more advanced? Or if it's spread?
Yeah, for advanced or metastatic prostate cancer, the foundation of treatment is usually androgen deprivation therapy, ADT.
Okay, back to the hormones.
Exactly. Since many prostate cancers are fueled by testosterone, ADT aims to drastically lower those hormone levels. This can be done surgically by removing the testicles, that's orchiectomy, or much more commonly now, with medications. These are drugs called LHRH analogs or antagonists.
Now, I've heard ADT can come with some pretty significant side effects, though.
Yes, that's definitely something patients need to discuss with their doctors. Common side effects include things like fatigue, hot flashes, loss of libido, potentially effects on bone health, and even cardiovascular issues.
Cardiovascular, like heart problems.
Potentially, yes. The guidelines we reviewed noted that for men who already have heart conditions or risk factors, certain types of ADT drugs, the LHRH antagonists might carry a slightly lower cardiovascular risk compared to the agonists, although more research is ongoing. It's an important consideration.
Definitely sounds like it. Now, I also saw the term treatment intensification used. What's that about?
Right, so that applies to men who are diagnosed with metastatic cancer right from the start, but it's still sensitive to hormone therapy, MCSPC, metastatic castration-sensitive prostate cancer. Intensification means adding other treatments along with the ADT right from the beginning. We know now that adding another powerful hormone-blocking drug like abiraterone, apalutamide, or enzalutamide to ADT improves outcomes significantly. That's called doublet therapy.
So hitting it harder from the start.
Exactly. And in some cases, particularly if there's a lot of cancer spread, doctors might even consider triplet therapy, adding a chemotherapy drug, docetaxel, plus one of those newer hormone agents to the ADT.
Wow, really throwing the kitchen sink at it early on in those cases.
The evidence shows it can make a big difference for those patients.
Okay. What happens if, say, someone has surgery or radiation, seems okay, but then their PSA starts to creep up again?
Yes. That's called biochemical recurrence, or BCR. It means the PSA level is rising after initial treatment, even if scans don't show any visible cancer yet.
A worrying sign, I imagine.
It can be, yes. It suggests there might still be some cancer cells somewhere. The guidelines emphasize that even a small, consistent rise after surgery is significant. And this is where those PSMA PET scans we talked about become really useful again.
To try and find where it's coming back.
Exactly. Is it just in the area where the prostate was, or has it spread somewhere else? Knowing the location is key to figuring out the next step.
And if it looks like it's just a local recurrence, say, after surgery, are there still options? I think salvage radiotherapy was mentioned?
Yes, salvage radiotherapy, or SRT. It's basically targeted radiation to the area where the prostate used to be. And the research is pretty clear. Starting SRT early, when the PSA is still quite low, ideally below 0.25, gives the best results.
Better chance of stopping it then.
Yes. Better chance of controlling the cancer long-term, reducing the risk of it spreading later. Our sources highlighted studies showing really good success rates with early SRT. Even if the PSMA scan is negative, if the PSA is rising consistently after surgery, SRT might still be recommended.
That's good to know there are effective follow-up options. Now, what happens when the cancer keeps growing even despite ADT? When the hormone therapy stops working? That's castration-resistant, right?
Precisely.
Yeah.
Castration-resistant prostate cancer, or CRPC. It means the cancer is progressing, PSA rising, or new spots showing up on scans, even though the testosterone level in the body is very low because of the ongoing ADT.
Okay.
Doctors need to confirm that testosterone is truly low before making that diagnosis. And then the treatment path depends on whether the cancer has visibly spread yet or not.
So what if it's CRPC but hasn't spread yet? Non-metastatic CRPC.
Right. For those men, no visible spread on conventional scans, but the PSA is rising quickly, what we call a short PSA doubling time. The strategy is to continue the ADT, but add one of those newer, more potent hormone agents. Enzalutamide, apalutamide, or darolutamide.
Ah, those names again?
Yes. Adding one of those has been shown to significantly delay the time until metastases appear. So the goal is to keep it contained longer.
Still trying to block those hormone pathways, even though the cancer is resisting the first line. What about when it has spread? Metastatic CRPC, that sounds tougher.
It is more complex, definitely. But this is where we've seen some really exciting progress. The guidelines strongly recommend doing comprehensive molecular testing at this stage.
Looking at the cancer's genes.
Exactly. Looking at the tumor's genetic makeup, and sometimes the patient's inherited genes too. This helps identify specific targets for therapy. It's becoming very personalized.
Okay. So what are the options then?
There's quite a range. You continue ADT, of course. Then you might use those secondary hormone drugs we just mentioned if they haven't been used already. Chemotherapy is an option. Drugs like docetaxel or cabazitaxel.
Right.
There are also radiopharmaceuticals. Lutetium-177 PSMA targets cells with that PSMA protein, delivering radiation directly. Radium-223 targets cancer that's spread to the bones.
Wow, targeted radiation.
Immunotherapy can play a role too, like Sipuleucel-T or pembrolizumab if the tumor has certain genetic features. And then there are targeted therapies based on those molecular tests.
Like PRRP inhibitors. I saw that mentioned.
Yes, exactly. PRP inhibitors like olaparib or talazoparib can be very effective for cancers that have mutations in DNA repair genes, like BRCA genes. Often, they're now used in combination with drugs like abiraterone or enzalutamide.
Gosh, that's a lot of different potential treatments. How do doctors even decide?
It's a very nuanced decision. It depends on what treatments the patient had before, how they responded, where the cancer has spread, symptoms, overall health, those genetic test results, and patient preference. It's really about matching the right treatment to the right patient at the right time.
Precision medicine in action.
Very much so.
I also saw something called metastasis-directed therapy. What's that?
Right, MDT. This is an approach for when the cancer has spread, but only to a very limited number of spots, say fewer than 3 or 5. It's called oligometastatic or oligorecurrent disease. MDT involves treating just those few spots directly, usually with highly focused radiation, like SBRT, or sometimes surgery. The idea is maybe by treating those few spots aggressively, you can delay the need for starting or changing systemic therapy, like ADT, and potentially improve long-term control. It's still being actively studied, but it's promising.
It's incredible how many angles they're attacking this from. Okay, let's bring this back to our listener. After hearing all this, what are the really crucial takeaways?
I think the most important message, really, is that while prostate cancer is serious, absolutely, our understanding and our ability to manage it have improved dramatically.
Okay.
Early detection, finding it when it's still localized, still offers the best chance for a cure. But even for more advanced disease, there's now a whole range of options that can significantly extend life and maintain a good quality of life for many men.
So there's reason for hope.
Definitely. Personalized treatment is key, using advanced imaging, using molecular testing to guide therapy choices. That's really becoming standard practice.
It's not just one path anymore. It's much more tailored.
That's exactly right. And the research is it's moving so fast. Scientists are constantly looking for new drugs, new combinations, even exploring if drugs used for other things, like metformin for diabetes, might help fight prostate cancer.
Interesting.
And we're learning more about lifestyle, too, the potential role of diet, exercise, and overall prostate health. Some studies hint at benefits from plant-based diets, for example.
That's encouraging. And the guidelines also seem to really stress the conversation between the patient and the doctor.
Hugely important. Shared decision-making. It's essential that patients understand their specific situation, what the treatment options are, the pros and cons of each, and that their own priorities and values are part of the conversation. It has to be a partnership.
So while hearing news like the recent reports about prostate cancer can be unsettling, it sounds like the reality of diagnosis and treatment today offers a lot more options and hope than maybe people realize.
I think that's fair to say. The progress is undeniable. Continuous advancements in both diagnosis and treatment are really changing the landscape.
Well, this has been incredibly insightful. Thank you. To wrap things up, what are the absolute key points you hope people take away?
Okay, 3 things maybe. 1, Prostate cancer is complex, yes, but increasingly manageable. 2, we have much better tools now to find it early and understand its specific type. And 3, treatment is highly personalized, with a growing range of options from active surveillance to very targeted therapies for advanced stages.
And perhaps the most important point for you listening, if any of this raises questions or concerns about your own health or the health of someone you care about, please talk to your doctor, seriously. Being informed is good, but talking to a professional is essential.
Couldn't agree more.
And with that, maybe a final thought to leave you with. Thinking about how fast genetic testing and targeted therapies are moving, what might prostate cancer care look like in another 10 years? It's definitely a space to watch and stay curious about.